putting yeah. No wonder. You felt pretty fresh.
We're going to get started now. So, hi everyone. Thank you so much for coming to today's Lunch and Learn on Maternal and Infant Health. We're going to get started with introductions for our wonderful panelists who have agreed to participate today. Starting with Miss Amy Leslie, MPH, CPH. Amy is a disease intervention specialist who specializes in prenatal and congenital syphilis. As the Area 7 coordinator, Amy monitors new cases, conducts case investigations, and ensures compliance for expectant mothers and their partners who are diagnosed with STIs, particularly syphilis, throughout Seminole, Orange, Osceola, and Volusia counties. Next, we have Miss Anissa Pilot, LPN, a perinatal coordinator with True Health, a dedicated LPN with a passion for reducing severe maternal morbidity through innovative telehealth solutions. With years of experience in maternal and child health, Anissa has honed her skills in providing compassionate care and support to expectant mothers, particularly those facing high-risk pregnancies. Next, we have Ms. Denise Dionese, a health educator consultant for the Florida Department of Health in Seminole County. With a background in mass communications, Denise has dedicated the past 12 years to working in maternal and child health in both Pennsylvania and Florida. Denise has also served as a certified lactation counselor and a peer outreach counselor in WIC. She currently works in the program of Florida Healthy Babies, a statewide initiative to positively influence social and economic factors and to reduce racial disparities in infant mortality. Next, we have Dr. Lori Boardman, MD, SCM, who currently serves as the Assistant Vice President and Chief Quality Officer of Orlando Health, Winnie Palmer Hospital for Women and Babies. Possessing skills in clinical research, medical education, epidemiology, and research design, she also serves as the Vice Chair of the American College of Obstetrics and Gynecologists Committee on Gynecologic Practice. And then last but not least, we have Ms. Constance Brown, BSN, RNDC, CCM. She is currently a board member of the National Black Nurses Association, a passionate advocate at the intersection of health and policy. Constance has dedicated the last 15 years to serving on policy committees for Black maternal health, Black infant mortality, and diversifying the nursing workforce. So with that being said, we're going to kick off with a few questions to get the conversation going. So question one I have for you ladies is, what are some of the prevailing barriers to accessible and quality prenatal care?
I guess I'll answer some. And so for what I have seen so far, a lot of it is going to be past medical issues that has not been addressed. Medical knowledge is going to be the very biggest one, because people don't know how your health associates with what's going on as your body is changing with pregnancy. Finances, mental health has been super big lately. Postpartum is a really big thing that people don't take into consideration as well. But other comorbidities that you may have that you don't even associate being an issue during your pregnancy is also a really big disparity.
So yes, one of the big ones being economic factors. A lot. For me, working at WIC, I saw a lot of issues with Medicaid and not getting it on time. Mothers who don't have insurance. Mental health, and education a lot. We take this for granted, and in our families maybe we know what's going on, but not every mom, not every woman knows how important prenatal care is. So a lot of that has to do with education.
One of the biggest barriers, obviously, is access to care and overcoming the historic mistrust of getting care through hospitals, through outpatient clinics. I think kind of breaking down those barriers to being able to encourage women to come into a safe environment where they're heard and where they're consequent, whether clinical conditions and mental health is enormous in this domain. They can really feel safe having those experiences.
Like, as far as getting into prenatal care, I usually work with women once they're already been tested and they've gotten into prenatal care, but insufficient prenatal care is a really big issue as well. They might have one or two visits in the first or second trimester, but aren't able to get in during like the third or so. A lot of that is financial issues, economic issues, transportation issues is a huge thing. So with a lot of our clients, we go pick them up and bring them in for their appointments and drop them back off. And I think there's a lot of fear and stigma against with medical mistrust and not understanding what is going on a lot of times with their own bodies.
All right, thank you, ladies, for answering the question. So, Ms. Khan, you don't necessarily work directly with clients in circumventing these social determinants of health and economic barriers, but you do work in changing those factors, in changing the policy that addresses those. So can you tell us a little bit about some of the bills that you and your organization have worked to get passed this year?
Yes, thank you. As she mentioned earlier, I'm a member of Central Florida Black Nurses Association of Orlando, and we're also a part of the National Black Nursing Association. And what we do is every year we go to Capitol Hill in Washington, D.C., and what we carry to our elected officials are what are some of the policies and procedures that we can advocate for in the Central Florida area. And I'll give an example. We go the first February of every year to Capitol Hill. We schedule appointments with our senators, with our Congress people, but we carry the issues we see here in Central Florida. This year, we just left about a month and a half ago, and our topic was inequities in Black maternal health. We had implication of Black infant mortality. Now, there were other topics we covered, but I'll save those for later. So what we're saying is, what we see in our local community, there are bills, and when we go to them about what we want to talk about with health policy, we look for a House bill and a Senate bill that matches that. So just know that you may not know about health policy, but there are people behind the scenes like myself who are talking to not just going to federal, but it starts with your local government. Going to your local meetings, talking about what you're seeing and what's happening and what you can do to advocate for your patients.
Thank you, Connie. So some of those bills and initiatives that you highlighted included working towards efforts in maternal health and telehealth services. So for the rest of you, I want to know, how do you think incorporating further telehealth services and using those towards those initiatives will impact your life health or your area of interest?
Before we get to that, I will mention that here in Florida, it's related to that. There was a bill that just came out, Healthy Living, the last 2 weeks. And in that bill, it's covering telemedicine for minority maternity care. So that Senate bill, which you probably don't care about the numbers, but 7016 gave $23 million. So the work that we're trying to do, it's important that we advocate these bills, because now this bill is going to provide telehealth for mothers with their maternity care.
And along those same lines, Florida Department of Health a couple years ago put out a Close the Gap grant opportunity. I work in Orange County at Winnie Palmer Hospital, and Orange County and Duval County were chosen because we were the worst in the state in terms of what maternal morbidity looked like. And we were able to secure that grant, and it was $2.4 million for both of our sites to run a one-year pilot. And the pilot really focused on, well, it was interesting. The pilot focused on Black and Indigenous women. Then we were told to recruit everybody. into this grant. This grant provided resources to our community partners, so we stood up a lot of community partnerships. We have, Orlando Health has a contract with Lyft, so we can use Lyft to take our patients back and forth to their visits. We've worked a lot with Second Harvest for food insecurity. We've worked with Center for Change that does a great work with chronic disease management, but also helps us with community health workers. So I think this, and I know that Anise has the extension grant, so we've extended it out to another 18 counties in the state of Florida with these monies to be able to really focus on that population that needs it the most, with getting those resources to them in a timely fashion.
Back to telehealth, the transportation, so as you mentioned, it's a big issue, yes, and this can be great in a way. It has to be done carefully, not to let some women fall through the cracks because a lot of times things can be mixed when we do it online, and it just has to be very, very, very careful. This is a fine line where this can be great or it could not. So transportation and providing transportation to me will be much more beneficial than doing it virtual or telehealth.
So this is kind of my wheelhouse. Because my program is SNMT, which is through telehealth. And so their initial visit, of course, I'm seeing them in the office, I'm providing them with necessary tools. Whether if you're there for maternal obesity, I'm providing you with the scale. We're talking about things, we're talking about diet, nutrition. If it's hypertension, they're getting a blood pressure cuff. And so with the benefit of the grant, I'm able to provide them all the machines that they need. From that point forward, they are meeting with me telehealth. We are talking about, how we're eating, we're making food diets, we're getting the plan through there. And then when they're able to come into the office and, see their providers, they see the, listing of what's going on, where their blood sugars are, where their blood pressure is. And so it is a second hand for those providers who see 20, 30 patients in a day to be able to keep in contact with what's going on with their patients. And to know that you have somebody who's there. My patients call me their nurse in their pocket because they have my cell phone. It is a direct communication. I am working 24 hours a day, 7 days a week. There's no such thing as, let me ask this dumb question, or she's not gonna have time, or it's the weekend and I'm gonna have to go to the emergency room when we can handle that right then and there with telehealth. So for our organization, which is True Health, we're right here in Seminole County. So Seminole County themselves has their own person, and that is me. And so that person will get hands-on experience, but I follow them for a year after, because pregnancy doesn't, the side effects and the issues that come from being pregnant and having comorbidities doesn't stop because the baby is born. And so they are following with me. We're still following weight loss. We're making sure that medications that are needed after or medications that can be stopped are continued when they get it back into primary care. So it follows them, and telehealth is extenuating. It really is, because when you have a lot of patients, but they have the comfortability of knowing that they have somebody. It's not just, I'm going to see you in 4 weeks when you come back to the doctor. And as far as transportation, we also do the same. We provide them with bus passes. We provide them with lifts. We provide them with transportation to get back and forth. And if I have to make a home visit, I'm not about it.
So Amy, before you jump into answering that question, you oftentimes serve as a kind of bridgeway between clients and care providers. Pregnancy can be a very difficult time for people. In your position, you oftentimes don't operate in just seeing people in a clinical setting or in a doctor's office. So in interacting with a client and garnering their trust to guide them through that process, where do you start? What do you notice is the best approach in helping these women or getting them to care?
So we work with some really sensitive topics, so the best way to start off is a completely non-judgmental way. Because pregnancy is a very common thing, but I'm dealing with a lot of clients who are going through extra steps during pregnancy. So we definitely have to approach them with a non-judgmental, this could happen to anyone type of way, and education is the way I like to approach it the best. Because a lot of people aren't, they may be heard of syphilis, and I also work with people who are pregnant women who have HIV as well. So they may have heard of syphilis or HIV, or you might be giving them some really life-changing news. So empathy and education is the way that I like to approach it the best. Letting them know that with syphilis, this is a very treatable disease. This is something that we can take care of, but that it is, when you're pregnant, it is urgent that we take care of it, and walking them through it, answering any possible questions that they might have, and bringing it down to a level of that everyone can understand, not trying to throw in too many fancy words, so that bring it down to everyone's level. Going back to some of the telehealth things as well, I think it's a great way to like bridge those gaps of insufficient prenatal care. Along with transportation issues, a lot of people have to worry about taking off from work. And I guess where maternal health is in the United States, not a lot of women get a lot of time off. They get what some places get 4 to 6 weeks, 4 to 6 weeks after they give birth to their baby, so they can't be taking off a lot of time during their pregnancy. A lot of people are saving up all of the time that they can. So taking off for going to a prenatal visit, because a lot of those offices only have 9 to 5 hours as well. So I think telehealth is a great way to limit the amount of time that they have to take off from work as well, and to better bridge that gap.
So, issues like congenital syphilis, despite treatment persistently being available, it still continues to persist in rising numbers we see. So, with that being said, why is it to you that, and for whoever else can answer this question as well, for those who work with those women, that with treatment so readily available, why is this still such a persistent issue? What do you find may be missing there?
So I would say for a vast majority of the cases that we get, where we are aware of those cases, the majority of them do get treated and do not end up as, their baby does not end up as a case of congenital syphilis. You do have those occasional cases for any various extenuating circumstances, mental health issues, falling through the cracks because I only take care of a certain area. So we all have jurisdictions, so people move around a lot if they're experiencing like economic issues where they're having to jump house to house, or we deal with people who have unstable housing, so we don't know how to find them. So other than those extenuating circumstances where people fall through the cracks, the majority of the cases that we do receive treatment and don't end up as a congenital case. A lot of the times when we're following up with a congenital case, we never knew she was pregnant to begin with. So we find out, they show up to the hospital and give birth. There was no prenatal care there to begin with. For a lot of various reasons, some women just do not have any prenatal care whatsoever, but we also get a lot of cases of women moving from different states or moving from different countries during their pregnancy, and so don't get that prenatal care towards the end of their pregnancy where they are screened. I was talking recently about some of the screening laws in the United States. I guess start averaging about 30 years ago, depending on what state you're in, they started implementing screening laws. So for diseases like syphilis, HIV, and a variety of other things. Here in Florida, they start screening at the first appointment, or first prenatal appointment, and then between 28 and 32 weeks, and depending sometimes at delivery as well. So typically we are able to find these cases with pretty good accuracy, as long as women are in prenatal care at some point. We do also sometimes get late cases where there was an infection late in the pregnancy. But I would say the majority of what we're seeing congenital syphilis wise is not prenatal care whatsoever or very, very insufficient.
Just to piggyback off of that, because we have a lot of late entry into prenatal care too, where they're coming in, they're already 26, 27 weeks. So now it's like you're under fire trying to hurry up and get them caught up to where they should be. And so sometimes finding out if they have those various illnesses or, different types of situations that'll also put them on a high risk radar, which then in turn turns them over to, high risk, maternal fetal high risk. Myself, who's also, who deals with high risk. And so it's education. Education has got to be out there. People have got to know how different things are affecting their body.
Does anyone else have anything else to add on that matter?
Just wanted to reinforce how education is everything. In this, we're talking about prenatal women, but the education has to start before. And we're talking about teens. We're talking about women that not yet are prenatal or not thinking of getting pregnant. So the education has to start from the root. So avoid that.
And then Denise, I actually have a question for you. So in terms of the demographic of women who are being served through WIC, those who qualify, who are falling through those services, the general average in Florida is 66.7% of women who qualify. In Seminole County particularly, that number has fallen to 56.1%. So with these women qualifying for services with WIC or any additional services, why is it that you've seen in your experience that those numbers may not be as high as they could be, or that maybe retention isn't as high?
Well, I'm formerly WIC. Yes, it's a struggle from year to year, but there is a lot of fear right now. A lot of our migrant workers are not wanting to come to the WIC office and get services. A lot of women don't have transportation. We go back to the same idea, but it just depends. Like with the pandemic, there was an increase, and then we go back. It's up and down, but a lot of fear right now.
And then pivoting from that, Dr. Boardman, if I could have you start off with answering this question, somewhat broad. Based off of your areas of expertise, how can we best prepare women for healthy birth outcomes?
I think getting women into prenatal care as early as possible and clearly preconceptual care so that they are in their best physical state. But again, this relies on patients being able to get to where they need to go and be able to afford what they can or cannot be able to get access to. So one of the ways that we've tried to close that gap, especially for recent women who immigrated to this country that don't qualify for Medicaid, we've partnered with a midwife bus who goes out into the community, goes to those high-risk neighborhoods, and just is there to do visits for patients. And so she'll see any patient. We've been able to leverage the money in the grant to get those labs done for those patients and make sure that when they come to the hospital, they feel comfortable and safe. So we don't ask those questions that would set up that situation. I think that the telehealth grant for us was really pivotal because in the pandemic, we had a lot of problems with postpartum hypertension. So women, the bulk of readmissions were from postpartum hypertension. So we started a telehealth program because at that point, nobody could go, courts offices had closed, patients weren't able to get the care, but the telehealth grant really closed that void. Patients, before they would go home, we would sit down and talk to them. They would get the blood pressure cuff, instructions and what to watch for, and then we did virtual visits. So in the first week, we did 2 visits for every patient. Historically, Black women are much less likely than have hypertensive problems to get a post discharge from after birth, having a visit, supposed to have one in about 7 to 10 days. White women, Hispanic women are like 70% likely, Black women are 20 to 30% likely. But what was happening and what is clear is women that don't have access to transportation, they don't have access to childcare, they can't go to those visits. This closes that because it lets them have care of their homes. So they could check their blood pressure, they kept a log, they knew when to call. We were able to get them into offices within 24 hours if they needed it. And at the end of the day, no matter whether you were Black or Hispanic or white, 70% of that population got visits. And it really closed that gap, especially for the patient population that was really at greatest risk, was able to do that. So I think it's a really great adjunct to the care that we do. You can do a lot through it, especially if you're really using the virtual platform. You can look at incisions to see if a C-section scar looks infected, or you can help a woman breastfeed, you can help a woman recognize early mastitis. So we did a lot to curtail those things from becoming worse, just using that platform. So I think there's a lot of opportunity there. I think this grant really is showing the benefit of it. Anybody?
All right. So pivoting from that, Connie, I know we talked previously about advocating to government officials for funding for these important priority areas. How is it that the Central Florida Black Nurses Association and the National Black Nurses Association pinpoint these needs, and what are we doing on a local level?
A lot of what we do is, all of you are probably aware of that community assessment that comes out, needs assessment that's done across the counties. And we cover multiple counties, and each county have different priorities. But what we do, our national look across the whole United States, and what are key topics that we can focus on. And maternal health has been on the list for the last 5 years, no matter what state. So for us, we as a local chapter look at what we can do locally, and some of what we've been doing is partnering with the health department and community-based organizations to see what we can do. Our organization's different. We're service-oriented. So we're not sitting behind a desk. We come out every weekend, and we're in the communities. And so I just realized that was a greater opportunity that we can be educated, because I heard you say education. So if we're in the community every weekend, we can continue to educate everyone we come in contact with on these health disparities. The key that everyone's been talking about are the social determinants of health. You know, that's what you're saying, is people have a problem with transportation. You know, people have a problem with food insecurity. And now we have a problem that hospitals don't even offer maternal care. I just found out in the region I live in, there's no maternal care there, that people have to drive a distance. So when we look at issues, we look at what's going on in our back door and what can we do to, you know, resolve those issues. There are bills that are out there that are just sitting on somebody's desk that they're not voting on. So the key is, you as advocates, is talk to your local officials about what you have concerns, like maternal health and mortality. And on a local level, we met with Congressman Maxwell Frost and found out what bills he supports. So, not to be political, but when you are going into the box to vote, you need to look if people you're voting for are really advancing what you need help with. And we're talking about this maternal health issue that continues. So look at government officials that are supporting the vote on these issues. There are different bills, as I mentioned, they're easy to look up, and that's what we do. So we're basically looking at what's locally going on within our community through community needs assessment, and then we're trying to see how can we partner and advocate with people like the panel here to make a difference in the community. And not just Black community. We know our name says Black Nurses Association, but we service everyone. And we have everyone in our organization as well. So it's about what are the health issues, but Black maternal health issue is at the top and it's been there. And so somehow we've got to figure with the policies coming down, can we get them to push the policies through?
Okay, amazing. And does anyone else have anything to add to that? No, okay.
She set it all.
Yeah, thank you so much. So a final food for thought question that I want you guys to think forward with, having a better understanding of roles, is how do you see your role growing to impact needed change in these areas? Where do you see in the future your roles expanding to and your potentially your abilities in reaching these populations?
I can go ahead and kind of start off on it. I see through these grants that we've been able to get, they've been extremely helpful. But my dreams were always I want a doula program, I want a real mental health program that we could count on, and I wanted a cardiac program. Because so many of these patients come in, they're having heart attacks, hypertension. Once you have hypertension in pregnancy, you're at a 4-time increased risk of having cardiac problems in the future. And we didn't have a lot of resources for them. So I have a fabulous MFM physician, Dr. Nwobi, and he has now found a cardiologist to come join them so we can start a cardiac clinic, not just in pregnancy, but for the time after the pregnancy. So when you lose the Medicaid after a year, what happens to that 23-year-old or 35-year-old who had that hypertension and had diabetes? But her long-term prognosis is not going to be very favorable if we don't continue to kind of interact with it. So that's about to be stood up. My doula program is going to launch in about 3 weeks, and that doula program is going to have doulas that speak Haitian Creole, who speak Spanish, so that we really can connect our patients with a congruent person. And then the final one is mental health. So doula is mental health and cardiac. So those were kind of the dominant areas that I think really begin to extend that reach. Doulas can drive your C-section rates down, but they also really help with just the physician nursing kind of dyad that you see commonly. And you know that if doulas work with midwives, we're even more likely to have a vaginal delivery, and that those patients' voices can be heard through the help of the doula.
Our job, my job, is to educate and create awareness for mothers to make the right decision, an informed decision. One of, she said, dreams, for me, it's breastfeeding being the norm. So we will continue working with that. One of the biggest things, and it's been really, really hard historically, is getting hospitals to follow this 10 steps for a breastfeeding-friendly hospital. We will continue pushing. We will continue finding ways to get bigger and stronger community allies to continue providing these resources for moms and normalizing breastfeeding and getting out there information such as the dangers of, shaken baby syndrome, sleeping safety, and so many other things that we as a community can get across to every mother, starting as teens. So that's it. That's the biggest goal, the biggest dream, to get much more community support and hospital supports with breastfeeding.
I have my own personal dream. However, I work for True Health, which is an organization, and the organization as a whole has opened myself up to more community things that I personally was not aware of. So being a part of this program, being a part of this initiative, our goal for our Sanford OBGYN team is for us to be able to make this a normal thing. It has to be normal. We have to normally have our primary cares going, hey, this is what's happening now. If you're planning on having children, then we need to make these precautions now. once people are pregnant and they're out there and they're living, this is supposed to be the happiest time of your life. This is, I mean, labor and delivery. I'm about to bring forth a person, and to know that that person can possibly come back stillborn. That person can have congenital diseases that could have been avoided just strictly by being out there, being open, and being able to speak. And so for a lot of people, they don't feel like they're heard. And so being able to provide them that knowledge to know that they can speak up, that you need to say, this is not feeling right, this hurts, this is, and for you to understand that this is taken as a serious thing. My pain is no different than anybody else's pain, and everybody who has been through any type of health education knows that pain is subjective. So if a patient is saying my pain is at a 10, but they're doing cartwheels across the floor, their pain is at a 10. And so this has to be something that's being considered normal. And so for us at True Health, we want this to be a normal. We want to be able to educate. We want to open up more OB offices so that we are reaching further than we are now. We want to stretch it across. We want to make this a norm.
So unfortunately, with my role growing is because our rates are skyrocketing. From 2012 to, I think it was 2022, there was over a 900% increase in congenital syphilis cases in the United States. And I think just from 2021 to 2022, there was a 30% increase. So significant jumps every year we're seeing with no, not even like jumping around, it's a constant uptrend. Here locally, we are seeing significant rates as well. We're seeing more of a jump up and down, but still a pretty steady uptrend in congenital syphilis cases. So as far as our role growing, we need more people to be doing this work, getting out there, and for there to be less stigma. I feel like in recent years, there's become more stigma. We were talking about this recently, that there's more stigma now with STIs than there have been in past years. And maybe a lot of it has to do with like partners and social media and things like that, but the best way for us to combat that is to normalize talking about these things as much as possible. So, and making all these things accessible. So one of the things that we do here at Seminole County in our STD program is we offer free screenings every Thursday. And during Public Health Month, every Tuesday as well. We have a screening tonight after hours as well. But so the reason that we're doing that is because we're one of the only programs in the area that does that. We have people come from counties away, like hour-and-a-half drives, to come get testing because they're trying to go get testing somewhere else, and it's $500 for just basic testings. So combating stigma, offering these things, these free testings, are where we're going to make the most impact, and constantly trying to like battle stigma is going to open that conversation between partners as well, which is where we're seeing so much of an uptrend in these diseases, is because we're not getting partner information from people. And so we're seeing lots of reinfections or people just being infected years ago and never knowing. So that's where we like see our role growing, is definitely that uptrend, but that's how we're planning to battle these things.
I see our role growing as an organization with the advocacy piece. And also what we thought about is putting out more literature, because I heard the word education. So maybe some more culturally competent literature that, as we know, we're in a community every weekend, we can be sharing that information with people on a daily basis. Also, I didn't mention that I'm also our grant administrator. So grants and talking with community partners, maybe we can partner more on some of the grants that they're working on to bring those nurses in that can help you. I know one partner just got a mobile van, that's what we could do to increase. We also train community health workers so they can become certified. Never thought about that until I spoke to a nurse a few nights ago, that maybe we'll add a component on our community health worker training to train those community health workers about identifying issues and what they can do as community health workers. They are our extenders as nurses in the community. There's not enough nurses. So I think our goal would be to continue to train people and provide education that's culturally competent.
You ladies have made some very wonderful points during this discussion. Actually, some of the things that we've talked about so far, some of the things that
You can have ours.
some of the things that we've touched on in these conversations is actually allowing for a further conversation on how we can learn from each other in terms of using these resources and how we can work together in that. So for example, Seminole County Health Department recently developed their own program with Mobile Health Unit, where we're able to get into different parts of the community and provide pre-testing for people with no insurance, provide family planning services, provide men's and women's wellness exams. As well, I was excited when you mentioned doulas, because we also have partnered with Miss Keisha Lockett of Empower Black Doula to have our own training here at the health department for training women, because doulas are beneficial to the community and they are beneficial to positive birth outcomes in navigating that. And actually, something that I really liked that Keisha had said, unfortunately she couldn't make it here today, but one of her strong beliefs is that, transforming birth starts with the birthing person. So in order to have better outcomes, it's not just about making sure that labs come out good, making sure that everything is by the book, but ensuring that the mother is fully knowledgeable of things, that she is making it to her appointments, that she is getting the assistance that she needs. So I think we had a lot of really great conversations in terms of that, and I'm very excited to see where these programs go in the future. I wanted to open the floor up to any questions or comments from the audience.
So with the stigma of women of color in maternal health not gauging their pain level as much as they should, and then they're not taking it serious, and then they either lose their lives or almost lose their life, or they lose their baby. Do you think that there is a push or a bigger trend for people to go from having their babies in the hospital and using a midwife in this current time?
I think personally in this current time, most people are looking for nurse midwives to assist them, and that's what they're trying to have a more natural birth. But a lot of patients are now looking for people that look like them. Okay? And so with people trying to find doctors that look like them, then we need to have an influx of providers that understand. And so again, education is not just for the patient or just for the nurse. The education needs to be for the provider as well. And we're having a lot of older providers who are still working with these younger providers that are coming in, and they're training this way. So the knowledge has to be full circle. It can't just be, okay, speak your piece and know your truth. You know what I mean? Because the doctors have to take that in consideration as well. When you're dealing with home births, of course, most of your home births have a higher risk of having issues, but the key is going to be if you have your prenatal care, do you know what I mean? Then we know what to expect. So you can take that to that midwife and say, is this something that you can deal with? Is this something that you can't? And then make an informed decision at that point. But I think as this is becoming more of a rise, more providers are realizing, yeah, this is a thing. And what can we do as providers to make sure that this doesn't happen? Does that answer? Oh, okay. Just.
I think more women are looking for the empathy level
Absolutely.
as opposed to just going in as a number or as a pay, or, you know, as a check for the doctor, whoever. They're looking for empathy when they go in for maternal health.
Absolutely, because nobody wants to be a number.
Right.
And we don't want our baby to be a number. We want to be heard. We want to feel like this is just as important for the provider as it is for the mom. It's just as important for that nurse as it is for the mom. And so that's why I love this program the way that I do, because I am able to be for that parent, that patient whose mom is overseas or whose mom is nowhere near, and I'm a first-time patient. I can mother that patient. You know what I mean? I can be that aunt that that patient needs. I can be what that patient needs at that time, because this is a scary process and a happy process at the same time. And we need that support. And I was talking about it earlier, it does actually take a village, but you gotta trust your village.
Hi, first of all, I think this is fabulous. I mean, it's great. We didn't really touch on this topic, but you mentioned it at the beginning. The mental health side, the postpartum depression. That I see crossing every barrier, and I'm just wondering what is in the works for that, because I just had a friend whose daughter, didn't actually got a great job, great gal, doesn't have a lot of financial issues or an inability to have insurance, but she had postpartum depression. My friend had to fly up there, and I mean, so it crosses every barrier or every diversity. And so I just wondered, what do you see in the future? Are you seeing those numbers rise? I mean, now that we have a name for it, I'm sure it makes it a little more prominent. But what do you see? Is there something that's being done to look into that side of the afterwards?
I think, like you said, starts with awareness. We are much more aware of that in every aspect, and including doctors and midwives. We are more aware as unfortunately cases are higher, but we are here to create that awareness that, like she said, not only to the women, not only to moms and but also providers. Providers need to make this a norm and screen for mental health issues. And something that you said that I really like, that the dangers don't stop just because the baby is born. These are 100 days of crucial after the baby is born for mom and baby. So 100 days of caring and looking really closely after these moms. And I feel like we're in the right direction. We're starting to see some changes there, but I do see where we see it going, that it's going to increase that awareness.
We know from data that's pretty recent, looking at maternal mortality, that the leading cause of death is related to mental health issues. More than bleeding, more than infection, more than all these other things. So it is probably one of the most common, if not the most common, complication of pregnancy, but it's also under-recognized. And a lot of it's due to resources. And so people struggle to get into getting care and getting access. We did recently also get a Department of Health and Human Services approval for funding for a program that would let us take those patients that are particularly ill, that kind of need that extra, more than a once-a-week visit, but kind of be in something called a day hospital, which is called also a partial hospitalization program, where you're able to get access to psychiatrists, psychologists, but also child life attendants, because you bring your babies into it so that you learn how to kind of work with your baby, because a lot of mothers that are super depressed or anxious, either when they come to you, they're holding onto the baby like you're on the Titanic, or they are holding the baby out like that because they do not know what to do and they're just not comfortable, and they end up not being able to take care of their children. So if we get funded, we would be able to stand up a partial hospitalization program through Winnie Palmer that obviously would serve a huge catchment area, because there's not something really similar to it until you go north of Gainesville. So I think programs like that and programs like the other, just getting perinatal mental health counselors that can be culturally and linguistically congruent with the patients they're gonna serve. So knowing your population and making sure that you're kind of tackling that end as well. We've been lucky to get grant funding, and trying to keep it to go forward, but it has to become sustainable and it has to be bought in by the hospitals. So we've worked hard at Winnie Palmer to be able to start that journey down the road of, they focused a lot on different populations, but everybody's afraid of a pregnant woman, right? They're afraid that you're gonna explode or that you're gonna, dentists call you to say, can I pull this tooth out? I'm like, please pull that tooth out, because someone's in agony, because people are so afraid of it, but we have to be not afraid of it. And we have to be also, when you have a mental illness and you have a child, there's so much guilt and there's so much other kind of emotions flowing that you have to also be very cognizant of that and be able to let people express that in a way that's not shaming them, so.
I will say, good news, some of the monies that's coming down from Tallahassee is for mental health for maternal. So there is money coming down that they just mentioned a couple of weeks ago. So I'm sure that'll get to the organizations that need to take care of and disperse it. So help is on the way.
I can say as a benefit, again, for True Health, because we have mental health people on staff. And so if we have that mom that is already coming in while she's pregnant with anxiety, depression, we can go ahead and start that now. We can start teaching coping mechanisms now. Because when you're pregnant, it can't take meds. You can't take bipolar meds. You can't take your antidepressants that way. Because are we transferring? So the question is there. And so if we can get them started now with those coping mechanisms as we come along, it'll give them the tools, not necessarily saying that it won't happen, but they'll have the tools. And they'll have somebody already in contact with that they trust in order to be able to reach out and make that call. And we have those stat visits where we can do a telehealth. We can have them come into the office. We can talk you off the ledge. I can come to your house until somebody else can get there and, and they can do that mental health session. So again, it brings us back to the ultimate thing, knowledge is power.
That's me. Any additional questions at this point?
Alright, well, I want to thank you ladies again so much for coming out and joining on this panel discussion. I think a lot of good information was shared today and a lot of amazing conversations were started. And does anyone have any final comments? No? Alright, I think we rounded it up pretty good. So thank you guys again. And